بگم بشینن؟ که تو بیای شروع کنی.
نه دینش gaat beginnen.
ببین این کلیکر هم میتونی کار کنی یا میتونی خانه رو کلیک کنی. اوکی؟
Ja, zeker. Oké. En dan gewoon doorgaan.
Ik doe het. Moet ik me introduceren? Ja. Maar ik ga even de zaal zetten en audio checken. Oké? Hello everyone, we're just checking some audio and visuals, making sure everybody in the hall and online is hearing me well. Everybody in the hall hearing me in the back? Good audio? Great. Everyone online, can you hear me? Right, I've got some thumbs ups here. Thank you very much. We would like to start with the session.
Good evening. It's really my pleasure to welcome you on this symposium, Transforming Healthcare Through Big Data. Since personalized medicine is possible and reaching because of the knowledge from all health data and statistics, I'm sure that the transformation in healthcare by the use of data will be at least as big as the change of Pasteur-landed antibiotics. So I would like to compliment the organizing committee to have chosen the transformation of healthcare through big data as the main topic of this symposium. For all of you who don't know, Maastricht UMC Plus is one of the 8 university medical centers in the Netherlands. It provides top-level referral and clinical care to an important part of the southeast region of the Netherlands. Together with the Maastricht University, it implements scientific education and research in close connection to patients' care. And for whom of you that came for data, Maastricht UMC Plus is an academic hospital with over 7,000 employees, and the Faculty of Health, Medicine and Life Science educates more than 4,000 students each year. Maastricht UMC Plus is a university medical center with a special focus. It distinguished itself from other universities through its integrated healthcare approach with focus on risk stratification, prevention of diseases, promotion of healthy behavior, and the organization of healthcare. And for all of these ambitions, the use of big data importantly facilitates the Maastricht research portfolio. Our research focus covers the entire spectrum of the innovation chain. With fundamental research, Maastricht contributes to generating knowledge. From that, it focuses on applying the knowledge through translation and clinical research. Maastricht UMC Plus develops treatments, interventions, and guidelines that contribute to a healthy lifestyle. Through this innovation chain, the Maastricht UMC Plus creates additional value. Value in addition to the direct economic effects such as intellectual property or cost-effective treatment, and this value is mainly reflected by a healthier population. In cooperation with our partners at local, regional, and international levels, we are able to control and optimize the entire innovation chain, from molecule or gene, via mouse and lab to the hospital bed. And for all of this, big data and the wish and needs to transform medical healthcare on that basis will be the subject of all other following speakers. Thank you for coming to Maastricht. Thank you for coming to this symposium, and I wish you a very inspiring meeting this evening.
Thank you, Helen, for giving this introduction as a member of the Board of Directors. I think this is your first official lead as 50+. because yesterday was your birthday, so that's why I want to give you some flowers first. Well, yes, as a chairman of the Department of Plastic Surgery, I also want to welcome you here in Maastricht and welcome you to this inspiring evening. I think the diversity of speakers will broaden our knowledge concerning big data. At least for me, it will probably, and I hope you will get as enthusiastic as I got the last few months. And I'm really proud of Parisa, who did her defense of the thesis this afternoon. She wrote, to my opinion, awesome thesis together with Samuel Lim and Hine Rakhos, who's probably doing the techniques there with the headphones on, and made a symposium possible, also with the help of the students and with Sander back in the audience. So thank you for that, and of course, not to forget her friend Merat there for the technical support also. You might wonder how we as plastic surgeons got involved into big data. Well, it's actually a coincidence because Parisa contacted me about a year ago that she did quite some research at Harvard Medical School with Samuel Lin, and I got immediately interested in the thing because we as plastic surgeons have some characteristics. We have to have a little knowledge about anatomy, a little. We work most of the time detailistic, so literally also under the microscope. We need to love to work in a team. That's very important for us. And we are innovative and creative. And the last thing in innovation is big data is something in the field of innovation. And if you hear something like that, you want to be in front of the developments. So when I heard about big data, I was immediately interested to work with this team, and but as I said, we are also creative. So we need also big data because we are one of the few medical specialties in which a treatment is not yet protocolized. For instance, if somebody has a defect in the face after cancer treatment, there might be 7 or even more ways to close this defect, and we don't know what is the best way. We just negotiate. We talk with the patients, we have our own preference, we have some data, but yeah, we have clinical trials, but you cannot do clinical trials in all patients. This afternoon there was a question of Professor Moroder about clinical trials, but I think I don't know the exact figure, but I think at least 50% of my regular patients would not be included into a clinical trial because they are excluded, because they are either too thin, too fat, too old, too young, they have comorbidity. So clinical trials are of course important, but they are not useful not perfect. They are seen as a gold standard, but to my opinion, it's not yet the perfect way, at least not only clinical trials, and that's where big data comes in. So if we can evaluate treatment in all kinds of patients with all kinds of comorbidities and all kinds of different type of patients and see the outcome, this could really help to treat our patients better. Because now I just always do with the patient what I think I would like to have done to me or to my family, based also a little bit on the science, of course. But I don't have the real evidence, to my opinion, and I hope big data can help us in that way. And there's also another reason to be more like, and actually that's really something that's actual now in the media. The whole discussion about ALCL, anaplastic lymphoma caused by breast implants. There's a 1 out of 12,000 chance to get a breast lymphoma if you have an implant. And if you get this lymphoma, you have a 95% that is treated just by removing the implant. And the media are just influenced by politics and by public opinion, telling us now that patients shouldn't use implants, patients getting scared. There are now really patients with BRCA, with a genetic disorder, having a chance of 80% that they develop cancer, and they formerly would do a preventive breast amputation, but because of some people saying on the national television that implants are bad, they don't do any preventive amputation because they have a 1 out of 12,000 risk of getting lymphoma. So we need also for these kind of reasons much more thorough data. I mean, still you have to fight against media, but if we can really prove using big data next to implants, next to trials, then I hope we can be a little bit more aggressive against the media telling you wrong, fake news, fake media-influenced news. And of course, we cannot solve this evening, but this meeting is one step into a direction to see from different views the problems we have to face, to get big data communicating with each other, all the different databases. And this is, for me, this is very interesting to see how the different people involved in different fields will solve this problem. So I'm very interested, and I hope, and I'm sure that this evening I will learn a lot, and this will be very inspiring to me, and I hope also for you. So thank you again for having made this evening possible.
Thank you all for attending this symposium about transforming healthcare through big data. We organized this symposium as a result of my PhD, which I successfully defended an hour ago. I am humbled and really, really thankful for all of you who are attending this event in person and online. I know there are people watching from all over the world, from New Zealand to Australia to Puerto Rico, so welcome all of you. So, how does this work? Let me see. Yeah. So I'm honored to introduce the speakers of today. I'm grateful for each and every one of them that have come from different parts of the country to share their knowledge and expertise with us, and so especially Dr. Lin, who joined us all the way from Boston. All these speakers are people that I look up to and that are really, really doing amazing jobs in the field of big data and healthcare. And I really hope that you're as excited as I am. Please give a warm welcome to all of the speakers. I will first start with a short history of big data and then introduce big data in healthcare. After that, I will introduce the speakers and who will share their knowledge and expertise. We will have a 15-minute break in between, and at the end, we will have a panel discussion. Let's see if this works now. Yeah. But before we go into the content, I want to share why I did my PhD and organized this symposium. The quote on the right is the Persian saying which says, "Mi tavan va boyett," which simply means we must, and that we can, and therefore we must. I believe that as physicians, it's our duty to provide the highest standard of care for our patients. We must therefore embrace and utilize big data. But what is big data and how is it transforming healthcare? I want to start with sharing my experience of a patient that I treated last week in the ER. And this kind of cases come along almost every day. It was Friday, 5 p.m., very busy at the ER, and an ambulance comes in and brings in a 70-year-old woman who had been experiencing chest pain for the last few days. The GP sent her in because he was afraid that this patient was undergoing a heart attack. So we did a full checkup, and while I was doing that, she said, "But doctor, I just have been treated in a hospital 10 miles from here, and there was something about my heart. It was last week, there was something about my heart, and they gave me some medication, but I don't know what they found. I don't know what medication I'm taking, and I actually don't know, but that's okay. It's in my medical record. You can see that, right?" I said, "Well, actually, we don't." She looked at me, "But why not? All of your colleagues did everything that you're doing right now." She looked at me surprised and shocked, and that is the question that we actually keep getting every day. "But doctor, how come you don't know what kind of medication I get?" I called the cardiologist on call in the other hospital and asked to send the information of this patient to me. And 30 minutes later, I received it by fax. Yes, ladies and gentlemen, we still work with fax in the medical field. Luckily, there was nothing going on with her. She was healthy, not experiencing any a heart attack, and she was dismissed. But what if this lady was unconscious? What if she couldn't talk? What if she was a foreigner? We can and we must do better. We are running behind in the medical world, and we're not benefiting from the digital revolution. So with that, I want to ask the audience, who of you have heard of the term big data? That's not a lot. Who of you know what big data exactly is? So there's a difference in hearing the term big data and knowing what it exactly is. So over the last few years, big data has become one of the most important buzzwords around the world. We've been hearing it everywhere. Big data in analytics, big data in Facebook, in Google. And it's been making impact and waves in other industries for quite some time. But in healthcare, we're still lacking behind. But what is big data, and what is the big deal about big data? To answer those questions, I go back, show you this picture of a fibula of a baboon, which was found in Kenya. It's estimated to be 20,000 BC. And this is how information physically looked like in the past. We, as humans, have been collecting and storing data as far as since ancient history. The reason that big data has been making an impact now is due to the digital revolution, because everything that we do, such as shopping, listening to music, is stored and is leaving a digital trace. With the advent of the digital revolution, our ability to store and analyze the data has changed the quantity of data that we can collect. And therefore, it is referred as our ability of the data being collected and our ability to analyze and make use of it. The term big data is not something new. It was actually first documented by scientists at NASA who were describing a problem they had with visualization, with all of the things data that they got from the universe. And they stated that it provides an interesting challenge for our computer systems. These data sets and information of the universe are so large and that they're taxing the capacity of the main memory, local disk, and even remote disk. It's been debated for decades now, a definition, but universally accepted definition does not exist. So how can we then explain big data? Well, usually it is explained using the 6 V's: volume, velocity, variety, veracity, variability, and value. And we'll go through each and one of them. First, volume. Volume refers to the data per transaction. It starts with bytes, kilobytes, megabytes, gigabytes, which is equal to 400 books. A terabyte, petabyte, and exabyte is all of the data that we had in the world up to 2003. So every day we create 2.5 trillion gigabytes of data. And this is increasing in such a fast pace that 90% of all the data that we have was created only in the last 2 years. The volume of information is growing so fast that scientists even had to come up with new numbers, the zettabyte and the yottabyte, and I believe there are now also more higher nodes of bytes. So healthcare data, in 2012 it was 50 exabytes. Next year it will be 2,500 exabytes. Just let that sink in for a moment, how much that is. However, we are only analyzing 3% of all that data. Velocity is the speed at which processes occur to make data available for use. You see here, I think you can see it better up there, is what happened in 60 seconds at the internet in 2017. And we see that the speed of everything, all the data going and coming is so high, and is getting higher with all the new technology that we have. Variety is the different types and nature of data. For example, you can have data in text, a picture, a video, or music. It's all data, but it's different textures. In healthcare, this means, for example, the diagnostic codes, the x-rays, the scans, or the blood results. And veracity is the quality, relevance, predictive value, and the meaning of data. It means, is the data accurate? Can we trust the data? Are there any typographical errors, or is it something that I really can use and trust? And variability. An important one, if you ask me, is the difference in the meaning of a variable. For example, if you ask a cardiologist, if the cardiologist writes down CP, she or he probably means chest pain. But if a pediatrician writes down CP, she or he probably means cerebral palsy. So if you want to compare and contrast data, what does CP then actually mean? Chest pain or cerebral palsy? And so there are a lot of different examples that the variability in data variables are very important. And finally, where we all have to look at the clinical relevancy of the data. What is the value? What does this mean for the patient who's sitting in front of you? What does this mean for the stakeholders, for the decision makers, for the hospital? So medicine traditionally has been a science of observation and experience, and for thousands of years, clinicians have integrated the knowledge of the preceding generations with their own lifelong experience to treat patients according to the Hippocratic Oath. Hippocrates was also the one who advocated for medical reporting, and he said that it should serve two goals: reflect the course of disease and indicate possible causes of disease. Due to record keeping, compliance, and regulatory requirements, the healthcare industry has traditionally collected and produced a large amount of data. So we're actually on a gold mine. So this is a tablet, for example. This is how we used to write down healthcare information. This is a medical recipe for poison, 2,000 years BC, found in the area what is now Iraq. And not a very long time ago, we wrote down all the information about the patients by hand. This is what medical recording looked like. But now everything is stored in electronic medical records. So to date, prospective randomized clinical trials or control trials have been considered the golden standard for developing clinical care guidelines. Is when you have the randomized clinical trials is when you have a treatment and you have you randomize group A and group B, and group A receives the investigational new treatment and control group is to control. But it's often not possible due to its time-consuming, expensive, difficult logistics, and there are ethical limitations and biases. However, with big data, we already have the data stored in electronic medical records of basically the whole world. And that's recorded in the MRIs or blood samples or scans, but also in the day-to-day data, such as the Fitbits and the Facebooks and the Google Maps. How often do you go out? How are you writing more depressive notes than others? And if you can save all of that in a data archive, with ensuring privacy, of course, do a data analysis and come up to new knowledge, then you can take care, provide better care for your patients, or prevent before a disease is happening. Because eventually, at the end of the day, it's because of that patient that is sitting in front of me in the ER and asking me, but doctor, why don't you have all my information in your system? I don't know which medication I am taking. So what we're going to talk to you about tonight. How can we translate this raw idea of big data into clinical practice? And how can we measure quality? What is quality? How can healthcare claims data transform healthcare? And what is the role of industry in transforming healthcare? And privacy? What is privacy? Who owns the data? If I go to the doctor with a headache and the doctor diagnoses my headache, is the diagnosis mine because I had the headache, or was it the doctors that diagnosed it, or is it from the electronic medical record who saves my data very safely? And which hurdles do we have in government? What is the role of Gdpr? All of these questions we are going to answer tonight, hopefully. And that concludes my presentation. Thank you for your attention. It is my honor and privilege to introduce the first speaker and my mentor of my PhD dissertation, Professor Samuel Lin. Professor Lin is an associate professor at Harvard Medical School and also the program director of the Harvard Plastic Surgery Residency Program. You're welcome to the stage, Professor.
Thank you so much, Parisa, and congratulations on your successful defense of your PhD and for putting on such a wonderful symposium. I look forward anytime I can to coming to Europe, and specifically on this joyous occasion. And so I bring you spring greetings from our young city of Boston that was founded only in 1630, as I learned from Maastricht, that was founded probably in the 500 BC range. When I think of big data, I sometimes think of Keanu Reeves as Neo, looking for the oracle in this whole mix of numbers and symbols in the matrix. And at times, that's what it sometimes feels like. But when we're talking about data, hiding within those mountains of data is knowledge that could change the life of a patient or change the world. We talked about big data, and typically in medical arenas, we talk about looking at our national databases, and I'll delve into more of the weeds later on in this presentation. But usually for a national database, we look at ones that are multi-institutional, but that have the potential for multinational data cohorts that can be analyzed. Rather than looking at only one hospital or one institution, big data really significantly increases the sample size, or the N. It really is data that's objectively collated by objective people, by a nurse navigator, someone other than the treating physician who may willingly or not willingly increase bias. It's widely available. It's funded continuously by the government, and it allows for broad trends across the country in terms of analysis. Now, it's not perfect, big data, that is, and there are disadvantages that we have to be cognizant about. It is a strength and a weakness that this data is de-identified, but because of the fact that these data are de-identified, there's a lack of patient-specific data in the medical chart related to pathology, the details of a surgical procedure that you may want to delve into or really drill down with. The inclusion criteria include our codes of ICD-10 and CPT, which may vary depending on the type of procedure, and you'll have 50 codes that describe one procedure in orthopedics, or just one procedure code that describes a whole host of procedures in plastic surgery, for instance. It doesn't count for outpatient complications, as these are typically inpatient complications in patients. It accounts for only a sampling of procedures at a participating hospital, and of course, not all hospitals are participating across the country. And so strategies for using big data usage in terms of healthcare and really translating what we have in terms of big data and taking it to the clinic and using it in clinical practice. We have to avoid the phenomena of garbage in, garbage out. How do we really curate our clinical question to be answered, and not just go through a study just to have a conclusion that may or may not be relevant. We have to know the limitations of the database, and by that I mean really trying to drill down and narrowing a narrow question, and also, for instance, knowing and understanding what types of databases that we're looking at. For instance, the NIS, the National Inpatient Survey, which we'll talk about later on, is good for instance, identifying trends over a longer period of time. And in plastic surgery, again, like I mentioned, the difference between outpatient and inpatient data sets that are different, very vastly different, and their related complications. Big data projects in our division of plastic surgery are really only one component of our research efforts besides our basic science efforts, but they also parallel our clinical material, our clinical cases, in order to try to help patients better. I'm going to focus on three different databases, big databases that we use have used a lot, and you've heard about earlier today with Dr. Kamali's defense. Starting with the American College of Surgeons National Survey Quality Improvement Program. So this was a brainchild in the 1980s from Congress that really was looking at the outcomes of the veterans, the VA system, and surgical outcomes reporting and improving the outcomes of our vets in the US. And by the early part of the century, it became the birth of the ACS NSQIP database, which is what is known today. It's gleaned from patient medical charts, it's risk-adjusted, case mix adjusted, but only accounts for a 30-day patient outcome period of time, which we'll get into as well. So what have we done and how has this been used related to the NSQIP database? And so starting with the head, we looked at, for instance, how head and neck reconstruction was performed. On the left side is a patient who had a squamous cell carcinoma of the larynx and voice box. This aortodigestive tract was removed and then reconstructed on the right side with tissue from the thigh, so a free tissue transfer from the anterior lateral thigh, which is a big procedure. And it hasn't always been performed this way. The free tissue transfer really became more and more popular in the late 80s. But we looked at this in terms of the databases regarding reconstruction with free tissue transfer, what I just showed, and also without. And does this increase the morbidity and mortality in these patients? We found that in these patients there was a longer operating room time, and that's expected, but there's an increased morbidity because of the length of surgery, but not mortality. We looked at patients in the head and neck with skull-based tumors and did this concept of transplanting tissue from one part of the body and putting it completely somewhere else, affecting morbidity and mortality. And again, we looked at these patients who, although increased in operative time was found, but not an increase in morbidity and mortality. And moving on to the craniofacial skeleton or facial fractures, in this day and age, facial fractures have become less in terms of mortality because of airbags, but certainly there is still plenty of morbidity from facial fractures over time. We looked at, in this study, regarding plastic surgeons, otolaryngologists, oral maxillofacial surgeons, regarding facial fracture fixation, and also the location of these fractures. We found that the most common fractures indeed still involve the mandible as well as the orbit in females, and the most complex facial fractures in this cohort were being treated by plastic surgeons regarding pan-facial fractures that involved multiple areas of the face as well as orbital floor fractures. Moving it down to the truncal area or breast in terms of breast reconstruction, this was a very key topic today that we talked about earlier. We looked at the rates of immediate breast reconstruction across all ages in terms of demographics. And we found that there were, although understandably decreased ages of immediate breast reconstruction with age, there was no associated rates of morbidity in these patients. And you may recognize some of these authors in the audience. One of the things that's come about in terms of immediate breast reconstruction and specifically implant reconstruction is the use of meshes and acellular dermal matrices, or basically skin from donors or other animal sources, the pig or cow, and using it to hold the implant as a breast reconstruction related to the implants. It came under lots of discussion because of the fact that really when you have single institutional data, it's all over the map. There's bias involved. You have papers that are being written that say it's fine. There are papers being written that it's not fine. So what is the answer? So a few years ago, we looked at the question, does ADM or acellular dermal matrix negatively affect implant-based reconstruction? And those negative effects, for the folks in the audience who don't have to deal with ADM all the time, relate to fluid collection that develops over time after a mastectomy and an implant reconstruction, wound healing difficulties, and infection. So in this group, over 19,000 patients we looked at and found that complications across both the ADM and non-ADM groups using the mesh were not significantly different, and notably both groups had an increase in complications as related to body mass index, diabetes, smoking, and the usual complement of risk factors when patients undergoing HAV surgery. A lot of us are in training programs and working with residents, and have really the honor and privilege of working in training with the next generation of our plastic surgeons and clinicians. There is this supposed July effect that you may have heard about in the media, which really talks about the fact that the worst time of the year to go to the hospital is in July in America. And then anyone know the reason for that? Parisa?
Because in July the new residents start in the US, that meaning that basically the newbie starts. So if you're treated by someone who hasn't seen a patient ever in his life, you've never heard that before.
Did you everyone hear that? Anyone hear that? Or know that before in terms of the July effect? So indeed, yes, thank you. It's the fact that no one wants to go to the emergency room in July because everyone just graduated from medical school. Who wants to go to the emergency room if they've got a 1-week-old physician that is trying to figure out what the correct end of the blood pressure cuff is? So with that, people have written about this fact of what the role of resident participation is. And so with this topic, autologous breast reconstruction, when we looked at these cases, we found that in the first quartile, or July, August, September, that resident involvement was not associated with 30-day morbidity, amazingly, and notably in cases earlier in this part of the year, had lower returns to the operating room and transfusion. And what does that really mean? That probably means that I and my colleagues are probably watching over these cases and more participatory in the beginning than later on. But it was an interesting sort of effect over these 2,500 patients. Moving on towards the trunk, there are frequently instances where hernia repair of the abdomen is concurrent with tummy tuck procedures or weight loss procedures when the amount of skin is still there from causing rashes. And so we looked at concurrent hernia repair with paniculectomy, abdominoplasty, or tummy tuck procedures. We found that there were actually higher rates of complications in these patients, but importantly, again, taking this big data to the clinic, you got to really weigh each patient individually with the amount of data that you have in your head and understanding who you have in front of you in terms of deciding what you're going to offer these patients in terms of surgery or not surgery. And it's also important to understand when it's not safe to operate. And I tell patients plenty of times that it's not safe, and I say that an operation may not be the choice for you. Component separation. Component separation is just a technique for helping deliver more tissue to be able to achieve a closure for a hernia. And I had one sort of thought at one point, when you have basically an internal corset or a binding effect of the muscles, whether or not that completed an abdominal compartment syndrome. What that meant was really increasing the amount of pressure so that you were slowing down the venous or the blood flow return to the heart, thereby increasing an increased risk of blood clot in the legs or pulmonary embolism. So in these patients, in this group, we looked at whether or not this was the cause. And we looked at this and found that component separation was associated perhaps with a higher wound and morbidity and mortality, but that the rate of blood clots and pulmonary embolism was not increased in these patients. Looking again into our residents and trainees, we looked at this year of past the July effect now. We're talking about actually now years of trainees over time. And we found that in these large body contouring procedures where we make large incisions to remove skin around the trunk, the arms, the breast, that increasing resident training level actually decreased the operative time, which I could believe for sure, and also the decreased morbidity as well. So go trainees. Moving on to the Healthcare Cost and Utilization Project, or really the National Inpatient Sample, NIS. It is a family of healthcare databases developed through an industry partnership with federal and state and the government. And it's really the longest collection of longitudinal hospital care in the US, derived from mainly administrative data on discharge records. And what this really is related to is regarding the fact of looking at trends over time of procedures across the country and costs and resource utilization. So moving back up to the head and neck region, this is a baby with several fused sutures of the head that basically turns the skull in such a way that the brain expands in different regions. We looked at these rates of hospitalization and charges across hospitals that have low volume cases such as these, intermediate volume and high volume centers. Found that the highest blood transfusion rates occurred in the low volume hospitals, and with the charges that were least in the high volume centers, but that there were no differences in complications. Moving on to another pediatric condition called cleft lip, where a baby is born with either a one-sided opening from the lip side or bilateral case. Again, looking at low volume, intermediate volume, and high volume cases, that the length of stay in these patients were lower in high volume centers, and that, however, cost reduction was not seen in these same centers. And then breast reconstruction, what was talked upon earlier by Dr. Kamali, looking at the incidence of 1- and 2-stage reconstruction, and what that really boils down to the fact that placing an implant in the beginning at the time of reconstruction versus as a 2-stage approach later on, both of those things really did increase over a 15-year period of time in the last 15 years, but that the 2-stage approach of a tissue expander, stretching out the skin, and then substituting an implant later on was increasing at a much faster rate than just a 1-stage reconstruction. Moving on to other more device-related issues, we use dyes, green dyes, different things, so looking at for the blood flow of the abdomen when we use this for breast reconstruction. Looking at these trends, we looked at the fact that over a longer period of time that this added piece of technology for reconstructive surgeons or breast reconstructive surgeons were able to use this dye and also increase the rates of debridement and use of debridement codes, notably, in these patients. So some of these databases and the studies that we ask in terms of questions lead us onto other paths and discoveries that we otherwise wouldn't have predicted. Moving on to, lastly, the Quad-ASF. This is actually an outpatient database that we used and looked at from 1980. And this is different from the other databases because this is an outpatient database looking at thousands of facilities across the world. And this is a white paper related to the DVT assessment that we looked at. We looked at all-cause deaths in this databases over 20 years. We found that 42 deaths occurred in these patients with a blood clot from really tummy tuck procedures, and that fully 60% of these patients were using the criteria that have been widely published, were either incorrectly assessed or absent at all. So based on this data, they made policy changes for the accreditation of these 2,500 centers across the world, about 1,700 centers in the US and 19 countries. So this is one example of at least how big data is changing practices and hopefully saving lives. So, we also have to really importantly, again, consider the source of the data. We know what the patients are in terms of their demographics and outcomes, and we really need data past 30 days. So finally, we're kind of wrapping it up. We looked at our own data in our own institution related to the NSQIP and really as a statement requiring the fact that this big data is still not without limitations, and it's important to really look at data past 30 days because many complications for different topics and patient issues occur past a month. I'm involved with the journal in terms of the outcomes section, so some of the neat things we're able to do have been recently to really parse out the outcomes and really further define outcomes as they were for our journal. Related to several categories that we came up with recently: patient-reported health or health outcome studies, cost, quality of care, and prevention. Different types of criteria that relate to these 4 main subdomains hopefully will be helpful for folks and authors in the future. We had a journal meeting recently in Dallas, and really both journals are always looking for collaboration, international collaboration around the world. And so what's new on the horizon? As we spoke about, big data does not only include national databases that we talked about. It can be society-specific. It can relate to accreditation agencies that I brought up, as well as insurance agencies. Our own plastic surgery organization, ASPS, has put forth a number of registries at this point related to topics regarding plastic surgery patients. Fat grafting is a hot topic for breast reconstruction and contouring and reconstruction. Obviously, we're talking about ALCL lymphoma, related implants related to breast implants and textured implants, and a small percentage of smooth implants. The National Breast Implant Registry has been started and probably borrowing more than one chapter from your own registry as it goes forward to really understand the key component of this, which is the denominator, which is, unlike the Netherlands, is a little bit of an unknown for us that we're still trying to figure out. And of course, insurance information from the outcomes that can be gleaned from the insurance companies in our country. So as we move forward in terms of the next stage of big data, we have to look at patient outcomes, as folks have talked about before, demographic costs, and also trends in rare diseases. We have to continue to leverage our professionals and also understand the fact that the consumer and patient perspective clearly is becoming central to how healthcare is delivered across all stakeholders. And so one purported thought is, and really interested to hear our other speakers, is really understanding how data collection is going to be tomorrow, next year, or the next decade. Whether it's going to be a survey platform from the healthcare giver to the patients and their families, and being able to somehow place this in a de-identified data repository, and also use artificial intelligence and machine learning to deliver the best care to our patients. This is a team sport. I want to thank our team members for sure. I want to thank Parisa. This is your day. Congratulations. This has been a fantastic afternoon. Congratulations on your PhD. We look forward to big things and big data from you in the future.
Okay, great. It is my honor to introduce the next speaker, Professor Valerie Lemons. He's the head of Department of Research and Development of the Comprehensive Cancer Organization of the Netherlands, the IKNL. He's full professor at Cancer Surveillance at Erasmus University Medical Center. Professor Lemons, the stage is yours. Thank you.
Thank you, Dr. Kamali. And it looks like I'm adding a seventh V to big data. Let me start. Let's see how I... this one's not working? No. Okay. Yeah. Thank you. Let me start with a statement. Big data does not save lives, and I will come back to that later on. Since I seem to be the only speaker who will focus on cancer this evening, let me show you how big the challenge is we are facing now and in the near future when we talk about cancer. In 2018, 18 million people were diagnosed with cancer across the world. And in the same year, 10 million people across the world died of cancer. And as you can see, it's not just a disease of the Western, typical baby boom society anymore. It's becoming more and more a global problem. And this graph shows very nicely how big this problem is growing in the future. Because in 20 years' time, 65% more people will be diagnosed with cancer than it is right now. Even more so, 75% more people will die of cancer throughout the world in 20 years' time. So you might think, okay, we live in a country we have modern, good healthcare, we have good access to healthcare, we think we live relatively healthy. Well, dream on. If you look at this picture, and this is age-standardized rate per 100,000 inhabitants, mortality, cancer mortality for females, and you can see the Netherlands is dark red. In 2018, there were only 6 countries in Europe doing less good than in the Netherlands. There were over 30 countries where mortality of cancer among females was lower than in the Netherlands. So we have work to do. How can data help us? When you're talking about cancer and data, it's good to identify 3 levels. At first, at population level. Second, data at patient level. And third, data at the cellular level. And I will go a little bit into detail for all levels. Now, it was also already mentioned very briefly, but of course, prevention is key. It's very important to prevent cancer. And how can data help us with that? Now, you see the same red colors again, but here now just the Netherlands, divided into areas and the big cities. Darker red, again, also here, age standardized, means a higher rate of cancer incidence per 100,000 inhabitants. And those of you who are familiar with the map of the Netherlands can see that the incidence of this particular cancer is higher in the bigger cities. Now, it's just one example. I can show you many examples, but I bet a bottle of wine if someone of you can guess what cancer type I'm talking about here. Cancer type which is most common in the big cities. What did you say? Throat. You said throat? I owe you a bottle of wine. Very good. Indeed, HPV related to sexual behavior at young age. Probably this will change due to vaccination now in the Netherlands. But there are many examples also related to pollution, industrial pollution, for example, which can be used to prevent cancer in the future. Now, these data that I showed you were from the Netherlands Cancer Registry. The Netherlands Cancer Registry as held by IKNL, where I'm working. This database now comprises almost 2.5 million cancer patients. We have full nationwide coverage since 1989. We have lots of person years and lots of data items, etc. We transform together with the medical specialist this into more than 200 peer-reviewed publications yearly. Still, I will call these data just medium big data, and later I will show you why. The nice thing of the Netherlands Cancer Registry that it's also comprising lots of data at patient level, clinically relevant data, and it's very nice if you add these data at patient level to a population level. And you can come up with graphs like this one. This is about metastasized colon cancer, only older people. Colon cancer is very frequent in the Netherlands. Half of the patient is 70 years or older. And here you can see a graph representing treatment in each hospital for this group of patients. So every bar represents one hospital in the Netherlands. And as you can see, if you were, for example, diagnosed and treated in the hospital on your left side, you would have about 20% chance that you would not receive any systemic treatment. If you happen to live near a hospital, which is depicted on your right side, the chance of being treated with chemotherapy and a targeted agent would be 100%. You cannot explain this to patients. So we see a huge variation in treatment in oncology in the Netherlands. Now, this was one of the reasons that about 10 to 15 years ago, we started to talk really seriously about quality indicators in the Netherlands. And before I will go into quality indicators in healthcare, specifically for oncology healthcare, I want to show you this example, because quality indicators is not only now a hype in healthcare, it's everywhere. In education, schools, everything is measured. And of course, also public transport. And I guess most of you can speak Dutch, and they understand the title, what it says. It says, trains are more often in time in 2018. And it also said that next to Japan and Switzerland, trains are not more punctual in any country in the world. Well, I'm a quite experienced train traveler. I travel, well, let's say 2 to 3 hours by train a day. And I want to give you an example of what I see happening very often, like 2 or 3 times a week. Now you see this man going in the train. He's the train driver. He was probably in the toilet. He was late. People trying to catch the train, but the train leaves. This is just an example of ordinary traveling by train in the Netherlands. Thanks. Of course, this train driver was nervous being on the toilet, and he was thinking, oh my God, I will be blamed if I start this train too late. Quality indicators. They are about trains being on time, while they should be about travelers being on time. And this is the parallel with healthcare. Also, when we are talking about quality indicators for healthcare quality in oncology, the focus is much too narrow, because it's not about how well a doctor or hospital is doing, it's about how well a patient is doing. And maybe last Friday you have seen the news. It had a lot of media coverage. The report by IKNL on the problems that lots of cancer patients face, even long time after they have been treated with cancer. They are still massive. And we do not have enough attention for these patients. I want to give you one example, just one example. I could give you many examples, but one example of where we were focusing too much on just a small piece of care and forgetting about the patient. It's an indicator about colorectal cancer, colon cancer, where we saw that about 20 to 15 years ago, that there was a relation between the number of lymph nodes examined and outcome for colon cancer patients. And it was even also myself, it was part of my PhD trajectory, where I showed this relation. And the hypothesis was that if you stage a patient adequately, the patient will receive adequate treatment and survival will improve. Sounds logic. And we saw that this lymph node yield was very low 12 to 15 years ago. We had a median of 4 to 8 nodes, while up to 12 nodes or more were considered as a minimum requirement. Of course, this was easy to measure. You could just count lymph nodes. So since the beginning of the quality indicator era in the Netherlands, this indicator was included in all lists. It was obligatory to report for all hospitals, for every patient that received surgery for colon cancer. So, pathology laboratories had to buy additional equipment. They had to hire additional pathology assistants because, again, colorectal cancer is a very frequent disease in the Netherlands. New methods, costly, labor-intensive, time-consuming, and of course, also more time had to be spent not only on finding these lymph nodes, but also, of course, paperwork administration. What did we expect? we expected, of course, a more adequate search for nodes. So we expected more nodes to be found by the pathologist. And indeed, we published this in 2014. The median number of lymph nodes increased from 6 to 16, and if you would look at 2016 and 17, it increased even more to about 17 or 18. Now, what would we expect then? We would expect, based on the fact that we found more nodes, there were more nodes evaluated, that we also identified more tumor-positive nodes. But nothing happened. No patient was staged more accurately. No patient was treated based on more intensive evaluation of lymph nodes. No patient survived more because of this quality indicator. We were chasing the wrong guy. We put a lot of money, effort, and time into this indicator, but for nothing. So let's go back to the data. Let's go to data to cancer at the cellular level. And we have to realize that at the molecular level, no two cancers are alike. And a small tumor of just 1 centimeter already comprises 100 million of cells. And each one of these 100 million cells can mutate, and this creates an infinite multitude of variations at the genome level. So this makes cancer an unpredictable moving target with no one-size-fits-all solution. And at patient level, nowadays a single patient generates 1 terabyte of data. This is just the diagnostic and clinical data. This is equivalent of 130,000 books. But when we are thinking of genome sequencing data, nowadays we also already generate 1 exabyte of data. This is the equivalent of 130, billion books. So genomic data, these are true big data by definition. However, the unpredictability of how a tumor grows and mutates and develops makes the task of finding an answer in all of these data, this mountain of data, even much harder. So the challenge is not to have more and bigger data. As it was shown already, we use only a small percentage of the data which are already there. And more data sources will emerge in the forthcoming years. It's more about finding the right tools and techniques, but especially it's about properly manage and effectively analyze the data, make better use of the data, make better use of the data which are already there. But we need to have special attention for bias. Just adding numbers to an analysis doesn't make sure that there is no bias anymore in these data. We have to beware of false interpretation. We live in an era of fake news. Well, here it's not different. Of course, we have to think about data privacy legislation, and we will have a talk about that later this evening. And of course, key is standardization of data. It was already said. Now, when we look at measuring quality of care in oncology, I think we have learned a few lessons. It's very important to choose our quality indicators sparingly and wisely. We have to focus on the patient and his whole journey. We have to standardize data input, and we do not want to have data collection relying on laborious handwork of caregivers, of doctors. We have to realize that we don't collect these data primarily for research. And especially the use of multiple already existing databases. For example, an interesting one, Vectis. The next speaker will talk about that. It's giving us lots of opportunities. But we don't have to strive for large central databases where we pool everything together, because decentralization is the future. And then you're talking about things like distributed learning, about a personal health train. And for those of you who are interested in this, just last week, IKNL published a vision document on data in oncology, data laten leven. But also one of the ministers of health, Minister Bruins, published a report, Data laten werken voor gezondheid, where he strongly wants to stimulate decentralization of data. Now, of course, the creation of clinically relevant and trusted insights is key, and this should be based on a combination of both population, patient, and cellular level data. And we have to transform these insights into health policy and clinical practice, for example, guidelines and decision support, because only this transformation of big data will save lives. What is needed? A greater collaboration between all disciplines involved. Also, especially a better cooperation between the public sector and the private sector. And I think this symposium sets a wonderful example. So maybe in the end we will succeed, and we can say this. If you got sick in the old days, you prayed to God to fix your health problems. Then you went to a doctor to fix your illness. And now you go to data to fix your health. Thank you very much.
Thank you very much. Are there any questions? Okay, we will have a 15-minute break. There will be coffee, tea, and a 10-minute break, I'm sorry. There will be coffee, tea, and some drinks in that after. After 10 minutes, please come back at time, because we're already walking behind. So thank you very much.
Zullen we die even doorheen praten?
rest van de 22 maanden zal jou ook horen
Oké.
in Zoom.
Ja, dat zien zij mij nu al.
Ja.
Okay. Hello, everybody. Welcome to the meeting. Really happy to have you all here. Okay. Welcome, everybody. I hope you have been enjoying the program so far. I want to kindly introduce the next speaker, Mr. Herman Benema. He's the CEO of Factis, the leading healthcare information provider in the Netherlands. Mr. Benema is an experienced executive with the strength in improving businesses based on analytical insight. Mr. Benema, please share with us how claims data is transforming big healthcare. Thank you.
Thank you, Parisa. The first question you asked tonight was, who knows what big data is? And if I ask that question to most of my friends, they say, big data, that's important in the future. But big data is happening today. It's important today, and I will give you some examples of what we are doing at Factis right now. Is there anybody who knows Factis? Well, more than one. That's great. Factis is an organization that makes information products for healthcare. And we do that based on a huge database we have. And what you also saw in other presentations, standardization is important. And everything we have is completely standardized. And what we have is a huge data warehouse. We have all the claims that are of provided care that are paid for by the insurance companies. And the total value in our data warehouse is about 700 billion euro, and that's growing with 1.2 billion every week. So to me, that's a lot of data. And with all this data, we have the opportunity to create integral insights in healthcare. We can follow patients, or we can follow patient groups. We can follow populations. We can follow diseases like cancer. And we work together with IKNL, with cancer. And I will give you some examples of what we do. And first, some simple examples, but later on, I will tell you something about data exploration. In Holland, the general practitioner is very important. He is the gatekeeper. But he only knows what happens in his practice. So what we do, and we did this together with the insurance companies, we provide the general practitioners with information of their whole population. So they know what happens with their population. And the average population of a general practitioner is about 2,000 persons. And they compare what they do with other doctors. And they discuss with insurance companies how to improve care. So this is one of the examples we have. And another is what happens in cities and even in neighborhoods. And this is an example of severe mental disorder. This city is Utrecht. And you see that you have big problems in smaller neighborhoods and smaller problems in other neighborhoods. We can make this, and we actually make this, for every city in Holland. So the insurance companies and the local government can work together, improving healthcare. And this is something else. I wanted to go to internet, but it didn't work. But if you go to something that we call zorgprisma.nl or factis.nl, you can make analysis yourself. For example, for expensive medication. But we have 22 or 23 themes, and you can make your own data. You can make your own information, and we have an open data set over there. This is a screenshot. And this is something new we did. What we can do is not only look at what happens in a hospital, but we can also look what happens before the person went to a hospital and what happens after. And this is the medication that a person uses before and after surgery. And you see in 53% of the cases, the medication that was used reduced. And this is the total level in Holland. We can drill down, and this is the level of the individual hospitals. And the first hospital you see, only in 50% of the cases, medication reduces. And the last one you see, in only, in 96% of the cases, it reduces. So this is a good hospital. Well, depends on what happens, but this is what people say, this is a good hospital. And the other, you have to find out what is happening over there. But this is used to discuss with each other. How can we improve healthcare? And if you don't know this, you have nothing to discuss about. And now something what we started doing about 2 years ago. Normally, we started with a hypothesis, and we did regular statistics. But what about the things you can't think of? So we wanted to have the data, give the data a voice, let the data speak. And first we started with something simple, with a patient journey. This is one patient, and this is the health care that was provided to that patient the 3 years before he died. And this is only one patient. And if you combine many patients, it is very difficult to do this. And what we did next was look at a very simple injury, a broken wrist. And you see the paths that patients can follow. And I will skip this one. I will come back to this one. And what we did, we combined these two. And we wanted to make a model that can predict the outcome of a kidney transplant. And we had to look at the 12 months before the kidney transplant till 12 months after the kidney transplant. And we made a model, and based on the care that was given to that person in the period of 12 months before the operation, based on these 12 months, we could predict the outcome. And we were right in 74% of the cases. We stopped here because we're not doctors. This is only based on data. And what we learned is that you have to work together with the doctors. We are data scientists. So we need the experience of the doctors. And then I go back to this picture. What we also wanted to do is look at the predictive value of cocktails of medicines. And we wanted to find out the predictive value of a stroke. And based on our data, the biggest predictive value was heart failure. But the biggest relation was a cocktail of medication. And what we did next was we removed vitamin D3 and we looked at the cocktail. And there was no relation between that cocktail and a stroke. And again, we stopped here because we are data scientists, we're not doctors. And that is one of the biggest lessons we learned. If you want to do something with big data, work together. And fact is, has no impact. We don't improve healthcare. We don't reduce cost. But based on what we do, the doctors can reduce cost. The doctors can improve healthcare. One of the last things we did was prostate cancer. And we, together with the doctors, we tried to find out how to increase the quality. And there was a very, very simple way. Increase the minimum level of interventions. And last year, the minimum level of interventions raised from 20 to 50, and beginning this year, it raised from 50 to 100. And the quality increases from 40% incontinence to 15%, and that is a big increase. And again, that's not something we do, that is what the doctors do, but the data can help. And what I will state is that the technology is fantastic. We used to do an analysis, and sometimes it took 2 or 3 weeks. And we have so much calculation power now, it takes us 2 seconds. So the technology is incredibly good. And next, garbage in, garbage out. The first speaker said it already. It is not a solution for poor data quality. Some people think if you have a big, great IBM machine, you put lousy data in it, you get great answers. That's not true. So you need to have good and standardized data. And knowledge of the data is crucial. We have a lot of knowledge of the data. But even more important is knowledge of what you are looking at. And focus. The first thing we tried to do was we wanted to find waste in the health system. We were looking for waste for 3 weeks, and these 3 weeks were waste. Because it's too big. Focus on a theme, and have a well-defined goal. But we are struggling right now. We are struggling with the AVG. The AVG is the Dutch version of the GDPR. That slows down what we do. We have data in different data sets, and if you want to follow a group of patients, you have to combine data sets. And actually, to make a good database for research, you have to combine the other data sets on the individual level to follow the patients, and then anonymize it. But then the law makes a problem, because we're not allowed to use the social security number for doing this. So we have to find other ways. And the strange thing is that the other ways we can use, combining other personal data, is less privacy compliant than using the social security number. So we wanted to expand the possibilities of the use of the social security number. And fact is, can't do it on their own. But the GDPR makes that possible. There is a possibility in the GDPR. And yesterday, Commissioner van der Zande brought out a report in which they asked the government to change the law and make it possible to use the social security number for purposes of improving quality. I hope that comes through, but I expect that it will take a few more years, so we have to struggle for a few more years. I saw questions.
Do you think structured data is the same as quality data? Is structured data always quality data?
No, structured data is not always quality data. Structured data makes it easier to interpret the data. And if there was CB or something was mentioned, in our database, CB is always the same. And that makes it very easy to analyze. But it is not quality data. It makes it easier to analyze.
We have a full room full of clinicians, and also online people are watching. I'm absolutely thrilled that we can hear this, because I also believe in a bridge between people like you and the clinicians. What is the first step to, if you have an idea and you think of using your database to start collaborating, and what kind of costs are involved? So I don't like to talk about costs. I like to talk about possibilities, but to give us an idea about how to start working with you.
Well, start working with us starts with one phone call. You can phone me, and the number is here. And I can bring you in contact with the right guy who is helping us. We actually did it with EKNL. Then the first thing is, what do we want to find out? What are we looking at? What kind of results are we looking for? And then we have to find out what is the data set we need. The second step is, after we know what data set we need, is go to the people who are responsible for the data. These are the insurance companies. We ask them permission. And the first time they say no, and the second time we improve the questionnaire, they say yes. And then we start. But the first phase is a difficult one. Sometimes it takes 2 months. I don't know how long it took before we started working together. 2-3 months? Yeah, a bit longer. Even longer. And
it was so much fun, you forgot how long it took.
No, but if you start well, you do what you are obliged to by law, and that is what we have to do. And what the price is, well, we work on a cost base, so the hours times €100, that's about it.
What would be the average price? So is it usually 15,000, or is it 100, or is it?
I can't say anything about it. This really depends. If there is a data set and already available, it takes us 1 hour. If sometimes we have a part of the analysis already available, so you don't have to pay for that anymore because it's already paid for. We don't have to make profit. But we did big research with IKNL that was about 50.
Yeah, what I remember was €7,000.
Oh, well, that was not a big one. That is €7,000. No, that's not. No, really, that's true. That's not a big one. If you want to use our data lab for 3 weeks, then we have 3 or 4 data scientists in it for 3 weeks with all the infrastructure. That will cost you about 40K. So that is expensive.
One more question.
Yeah. Hello, my name is Martin Hoekberger. I'm one of the plastic surgeons in Eindhoven. I'm very much interested in health-related quality of life and use those data with clinical data to come up with algorithms for shared decision making. And I'm struggling how to combine our data, because I've got quite a bit of data regarding this health-related quality of life in at least 3 groups of patients, but I want to get beyond that point by just collecting data, but doing something with it to enhance the quality of care to our patients. How to proceed?
Well, first, I think it's very important that you came to the point that collecting data is not enough, because in the end, nobody wants to send the data to you anymore if you don't give them information in return. That's the struggle we had 8 years ago. Actually, just start. And just start is, please start small, but you can start on your own data. And you can also start together with people from us. We can help you by doing that. But there are more companies. Dutch Hospital Data, for example, has a lot of experience in doing this. But the fact is, most people, they think and think and think, and they never start. You have to turn it around, because only by starting you learn. So start, make mistakes, learn, improve, but start.
Thank you, Mr. Benema, for your interesting talk and valuable insights. It stirred up a lot of questions from the audience, and we will further discuss it in the panel discussion. The next speaker is... the next speaker is someone that I really look up to, Mr. Hans Alois Wischmann. He is the Innovation Program Director of Philips Healthcare. He, as a head of Philips Research, he for a while moved to Cambridge, Massachusetts, and built collaboration and partnerships, and he's back in Europe from 2017 again, and is responsible for the research programs in healthcare informatics and population health management. So Philips has received funding from the European Union to use big data and artificial intelligence to improve healthcare. Please, warm welcome for Mr. Wishman.
Thank you very much. It's an absolute honor to be here and to be asked to speak on this topic, but actually it's much more of a pleasure than just an honor. I wanted to violently agree with Mr. Benneman, as the previous speaker, that while many think it's coming, and your PhD showed that it is here, actually the people who now think that it's here have missed the train 15 years ago, because that's when we started with an NIH grant and a collaboration with Beth Israel, with the affiliation of Professor Lin, to curate data in the intensive care unit. And you'll see at the very last of my slides that it's a product now and able to predict things happening in the intensive care units hours before it actually happens. So the value of structured data is one question that you just answered very nicely, but it's actually putting the effort in together and curating the data, and starting that early on is, I think, where the industry, public-private partnerships play a role. You asked me to talk about big data in healthcare and the role of industry, and so coming from a scientific industrial research lab, our intent is actually to move the science that you and your colleagues drive forward into solutions that make it to the bedside. Take industrialization constraints and feed that backwards into science and say, actually, this is a wonderful idea, but if you're 60% accurate, you don't want to try it in healthcare. Go try to predict something in the color of the tie that I wear next time. But in healthcare, if the tram doesn't go 2 days a week, you wouldn't be happy. And if a patient isn't served right 2 days a week, you won't be happy. So the level there is so much higher. That's where we try to go. We also try to bring science to the hype. In the sense, I'd like to pick up on the things in your defense earlier today, where you had a proposition which was, if I quoted correctly, without data, you're just a person with an opinion. And then your corollary in the defense was, with data, you can underpin your opinion to make it into an argument, paraphrasing slightly your answer. We see our role in the partnerships to take it one step further. Because with big data, as you so nicely pointed out, if you have correlation, that does not mean that you can do anything about it. Correlation from big data is a rear view mirror. What you need to do is close collaboration with the clinicians and with the academics to go one level higher, to distill those correlations into insights, to synthesize hypotheses out of that, to try to rationalize and say, out of these hypotheses, this would be an intervention that we could try, to try to see whether your data actually underpins the intervention, to then go through the ethics and do a trial and to try to see whether it really does the outcomes things that you want to do. So in that sense, I think we share amongst us here, and it's a wonderful team that you're bringing together, a bit of that vision. And the one thing that this very modern artistic representation of your digital twin wanted to remind me to talk about is that while you can be great at predicting an aircraft's engine failure, and the complexity of that system is probably similar to a human, there is one fundamental difference. And that fundamental difference is choice. An aircraft engine has never taken a drop of oil and said, no, thank you, I'm not going to take that. And a patient, I've seen many, just on the science side, say, yes, doctor, I've taken my medication. And that was totally wrong. And that was, so there is choice in the human behavior, which means that even if you've got good indications at population scale, doesn't mean that you can do the individual a good job. Let me try to see whether I can move this forward in the right direction. Yes, I can. Why are we in this? Well, we as a company aim to make an impact on 3 billion lives a year by 2030. And that isn't sort of intrinsic motivation. It is of doing something good to society, but also the economic benefit of touching so many lives. On the other hand, it's also why people do want to come and work with us, because it is so much more gratifying to apply artificial intelligence and big data to predicting something that you can do to a human to help than to predict the tie that I may or may not buy next week. That is an intrinsic motivation. The extrinsic motivation is a bit, you have alluded to it, the difficulties in healthcare are So big that if you start and do the right things and have a focused question, you can move it ahead. Because in spite of all of the tsunami of things that are coming at us, if you look one level deeper, there's just not enough of you and of us to deal with this population. All of us are getting older. We live longer with more diseases. There is a shortage of skilled caretakers and skilled medical professionals. Leave alone the monetary waste. There's just not enough healthcare providers to help us enjoy a good retirement age. The question is, can big data and data science help? While I totally concur with you, big data alone has never saved a life. Without it, you're a very poor man in these days. It isn't gold, and I would like to mention that here we shared numbers of what petabytes of billion images, of million hours on our machines we manage, but that does not mean we use. We are very mindful and very respectful of GDPR. We're finding ways to do our work in total compliance. I actually sign off all of the 400 studies from a privacy perspective that we do in Philips Research every year. We want to move it forward, we can move it forward, and we're very mindful and respectful. So yes, there is a lot of data, but what does that mean? It means that we have more data than we can turn humanly into insights. So we need some data science and big data to help us with it. If AI or machine learning can help us recognize patterns in data that are too complex, and your question, Mr. Benneman, was to find things that you weren't even asking for. That is wonderful because that extends our capabilities. However, we still need to work very closely to make sense out of the correlations that we found to take it one step further. Why are we able to do this? So not showing Moore's law because it was actually not the processing power. When I was a PhD student, I had access to enough processing power. It was the data that was not available in a digital format. And I was very much touched by the slide that you had in your presentation, both at the defense as well as earlier this evening. This here looks at the storage capacity and the price of storage. And I mentally did a back of the envelope on that little cuneiform tablet that you had. It has about 100 kilobytes of data. So if you look back in the 80s, we had floppy disks, which had 360 kilobyte. And now you go back 3,000 years, it's about there where the window is, and you already had a third of that. You look at the price of it, and just for comparison, the Nineveh library had about 10,000 tablets. At 100K per tablet, that's about a gigabyte. So it may have cost about 10 million to construct that library and put the 10,000 tablets in, but that gives you also an indication that over about 4,000 years, that price hasn't really come down much. The Romans, by any chance, were much worse. Their stone tablets didn't have the information density. But so the next version I have of this slide will have 3,000 years of history coming parallel, and then suddenly having this explosion here. It's this data, if we turn it into insights, that can make us make a difference. Again, a word of caution that I need to always give to the people in my environment and beyond. This is a proposal that 2 months, 10 people could try to do something over a summer project, make machine use language, abstractions, concepts, solve the kind of problems currently reserved for mankind, and that over summer we could make a big difference. And if you read the fine print, it says this was a proposal from 1955 by the giants in this space, Minsky, Rochester, Shannon, and they thought it could happen immediately, and what they were actually lacking was curated quality and structured data to make many of these things happen. There were a few algorithmic improvements, but they were mainly in the 80s, 90s, a bit in deep learning earlier this year. It's late in the evening, so I thought I'd do a quick mythbuster. Which of these statements could be true? AI-enabled systems will drive a car about as safely as a human by 2020, autonomously land an airplane by 2025, and replace radiologists by 2030. Show of hands for the first one. Show of hands for the second one. Show of hands for the third one. Okay, here goes. Drive a car about as safely, that was in 2016. Autonomously land an airplane, 1937. Actually, we sometimes use metaphors that radiologists are so important because, like with an airplane, the autopilot can only work in good weather and can only land an airplane in very good weather. Well, actually, in some cases, early on, we've well outperformed humans. with systems that accurately have models of their environment and accurately sort of can land an airplane. And actually replacing radiologists, I think nobody wants to do that anymore. Everybody wants to augment them, and we believe that that has been done in 2017, 2018, when the first solutions actually came into regular clinical practice. So way beyond initial research attempts, but where they can be using and augmenting them. We need to be a bit mindful of these, specifically when we use metaphors with the general public, with media, the sort of thing with the landing of an airplane and the self-driving car, it goes wrong every time. So AI, I'll try to be mindful of time. We try to say that you actually need the toolbox and the tool chests for creating insights from curated data, but you need to combine it with clinical and domain knowledge to make sense out of it and to turn it into solutions that really make sense in daily practice. You need to augment providers, you need to empower patients, and you need to enable the population health things like you were showing. Without the insights that you have, the medical professionals will not be able to create hypotheses that they can try out and actually move science ahead. You're very well aware of how difficult it is to move guideline-based care ahead. We believe that by benefiting from the guidelines and the data and the AI tools, you can move science ahead faster in a controlled way without doing randomized controlled trials for every one of us in the 10 billion population. But we object to people saying, oh, I'm going from usual care straight to AI and outcome-based care. I'll just do reinforcement learning. And we say, you don't want to do guideline-based care in the control arm? And say, no, we don't do that here. And then we said, then we won't work here. So the thing is that you do need to leverage the thousands of years of experience that you also alluded to bring that in combination with the additional insights and correlations that you're seeing. And then you can be extremely powerful. But it's in that close collaboration, in that close partnership. You may have seen this, which is the one I referred to, where while looking at the data, a radiologist gets information about relevant previous things, about semantic context. We know from a probabilistic map what part of the anatomy the doctor is currently looking at. We can make a mental model of what question he or she is asking. And then if the mouse pointer is hovering over a bright spot in a chest CT and there's no prior sign of a lung nodule, we may want to volunteer a quote from the guidelines to say, incidental finding, lung nodule, no prior history, no family risks, suggested follow-up 6 months with a CT. Doc, is this okay? Do you want to put it into the report? That's the vision we have with the final sign-off still there, but augmenting and assisting with the additional things that we can bring to lever from the technology. I'll skip this one, and I'll just try to focus for the last 2 slides onto what is guiding us beyond the vision of wanting to make a difference, make an impact on 3 billion lives. It is more and more the understanding that we need to look at multiple axes. It's not just a quicker throughput of a reading an exam. It's not just a better user interface that facilitates that and eliminates repetitive strain injury. It's not just lowering the cost of care. It's a combination of those, not always in all solutions, all of them, but this quadruple aim, which was spearheaded in the US, really looks also at the practitioners, at the healthcare professionals who are burning out almost as much as air traffic controllers are under the burden of the workload, of unnecessary things, of things where we have not taken the lessons seriously enough. So in co-creation, what we try to strive for is both better health outcomes and a better patient experience, because specifically in the US, that's what also counts for the hospitals and hospital systems. Lowering the cost of care for society, but improving staff experience so that people will stay with their profession so that they can actually help patients more over time. I will stop on this final example and come back to my initial words 15 years ago with an NIH grant, with Beth Israel, MIT, and Philips. We started compiling that database MIMIC of now 40,000 ICU encounters. If you see that an ICU encounter is typically more than 24 hours, the math says it's more than 1 million hours. And so we've come back and created a solution that picks up on subtle combinations of vital signs combined with lab values, combined with prior history, that allows us to predict, not in every case, but in 1 out of 3, 1 out of 4, that a patient is going to run into trouble a few hours down the road. So instead of scrambling because the patient has just run into a problem, it provides an additional time window of consulting, of bringing the right people in, and of taking the decisions. And again, when we had that, everybody said, yeah, nice to have, let's put it on the side. Until we had run a study and proven that it does have an impact on cost, on outcomes, on the patient experience, and on what actually the staff experience is there, it didn't fly. Once we had that, it doesn't sell like sliced bread, but it is recognized as an important tool, and it is taken up not just by the clinical partners, but also by the business partners by saying, yep, you're actually onto something. You've found something like that. Partnering across the aisle and looking at how we can get more of this with longer-term outcomes. The HCAP data mentioned, we use them in some of our research work, of course, also. It's trying to bring the things together, but as you were saying in your defense, it's about the communication, it's about bringing the people together, and it's about avoiding the unnecessary hypes and saying, okay, after the next winter when we come out, there'll be solutions that have AI inside, which are so much better than anything we have now, that it's worthwhile staying the course. Without further ado, I would like to thank the audience for having me.
Any questions? Sam.
Thanks so much. I wonder if that was with John Halamka at Beth Israel Deaconess, or was it one of the ICU anesthesiologists that you partnered
It was with the ICU anesthesiologists. Currently, we're extending it to the emergency department with Stephen Horng, and trying to say, why start the clock when the patient is transferred into the ICU? You've got 4 to 5 hours of emergency care before that, and try to figure out a way there. And to your point of identification, yep, we had that same problem. It's not just that the data cannot be combined based on GDPR or other things. It's actually that in the emergency department, there's not enough time to enter the patient data into the monitor or other things. And your colleagues have said, well, but the heartbeat will not be so different from the moment he leaves the emergency department until he gets into the ICU to retrospectively bring data sets together. So it's always this partnership, this take and go, which allows us to surmount some of these obstacles.
Yeah, thank you. Great talk. Just so briefly, one of the slides that you kind of came across was improving staff wellness. And so I was just seeing on one of the push emails I saw on the way over here across the pond was that one of the JAMA or AMA studies was that wellness studies actually don't improve wellness for staff. So I wonder about what kind of window into the future smart devices that fellows might be thinking about to improve staff wellness, and rather than the amounts of data that we do input from an EMR standpoint, paperwork standpoint for our daily patient care.
Unfortunately, I don't have a silver bullet for that. It's a tough problem. What we try to do is look at the things that you are doing and co-create solutions around that instead of putting it in front of you after we've sort of gone through the design. That at least eliminates some of the interaction difficulties. On the other hand, I sometimes hear the e-scribe. Somebody just want to type the things that the doctor is saying anyhow, and I scratch my head and I'd like your opinion. What the doctor types into the EMR may not be exactly what he's telling or she is telling the patient, but may be more of a richer nature, maybe in more technical terms. And so the e-scribe that many people are propagating, I don't think it's the real solution. We need to come up with better things, but we're not there yet. I don't have a solution, but I welcome your ideas.
I also have a small question, if I may have the last, I think, because we need to move on. But for you, the same question. There's a lot of people here that have databases, clinical databases. We all are, I was talking about myself, amateur analysts. And we're looking for parties that have access to artificial intelligence and things like that. Is there something, how does Philips approach these kind of things? Are you a potential partner to look at these things, or what are your thoughts on this?
Yes, yes, and yes. So both with respect to the European models of public-private partnerships under grants, as well as, if you're open to that, we have clinical master research agreements with multiple institutions where we do an exchange. We are even open to bringing in rotating visiting scientists if you've got a clinical problem, and if you're willing to host one of our scientists to look at the data with you. As long as we can get the GDPR and the consent correct, we're absolutely game for all of those. We want to get out from behind our desks. We've got the infrastructure, but sitting together is so much more fruitful than even being just at a bike's ride's distance.
So we call you, just to be sure, and we sit together. That's the first step.
I come here, and next time I bring my people.
Sorry, the boss says we have to stop here. No, but
Sorry.
no, that's fine. It's fine. But we need to continue. We need to continue.
We will have time at the end at the
Yes.
panel discussion, otherwise it gets really late. The next speaker is Professor David Townend. Professor Townend is a professor of law and legal philosophy in health, medicine, and life sciences here in Maastricht University. And I personally look forward to his talk because he focuses on data protection and privacy in the medical and health research. Welcome you, Professor Townend.
Well, I'd like to start, of course, by congratulating you on a wonderful PhD and a great defense this afternoon, and on this tremendous symposium as well. I've learned an enormous amount, and I've heard about the Gdpr, the spectre at the feast. Well, is it? I want to explore a couple of things, really. One of them is what is the sort of scope of the Gdpr and how might we understand it. I want to talk a little bit about privacy underpinning that. And I want to just start with what Andre Decker said this afternoon. Why can't we just link everything together? And you gave a glorious answer and resisted the temptation to say, well, because of the law. And I'd like to show that it might not actually be the law that's getting in the way. What do we know about what people want from these new technologies? Might be a strange starting point from a lawyer, but I'm very much into socio-legal studies, so I'm very interested in the effects of the law. And we seem to present a bit of a contradiction. When we walk into MUMC or RZM or the hospital, we want to be cured. We don't really want an answer that says, well, we would have been able to, but. But as we walk out, we want our privacy. And I think we also need to distinguish between those who are patients, because once you're through the door, there's a good argument that, well, anything goes because you no longer have a problem with your insurance or your employer because the thing has manifested itself, and yet to be patients. And one of the things that might be a difficulty in the law is where do you pitch the law? Who is your target audience, if you like, when you're thinking about the law? And I think we've perhaps erred on the towards legislating for the yet-to-be patients. Now, I don't know what everyone in the room is like, but I'm guessing there's a bit of a range of sensitivities here. If we look at the Eurobarometers, there's a range of sensitivities to all of these difficult questions that we see. And I'll bet that there are some of you who, we've been confronted with a lot of things about cancer this evening, haven't we? And I should imagine some of you are thinking, oh, crikey, cancer. But if I ignore it, then it'll probably be all right. It'll be, yeah. And then others will be saying, bring it on, yeah, come on, yeah. There's a range. In all of these things, where your responses will all be different. And yet the law seems to go for the middle ground, perhaps, or the conservative ground. Who are we actually legislating for? So I think one of the things that we need to start with is this idea of what do we want as a public? And I think that the notion of public engagement, how people actually make their choices, what is in the frame, how we have to react with other people about their sensitivities, be that the ones who are really frightened or the ones who are really confident in this. How do we cope with each other? And I would refer you to the glorious work of Mike Burgess at the University of British Columbia on this, which is quite groundbreaking stuff on how do you actually find out what people are thinking and how people think about these things. Okay, now one of my notoriously difficult slides. I'm not a great one with technology, really, so It ends up looking like this. And I suppose one of the problems is here, we're dealing with essentially secondary processing of already gathered data. Secondary processing of already gathered data. So the red boxes on your left, yes, not watch, are different sets of identifiable personal data. So that might be from different hospitals, it might be from different research projects, all sorts of the data that we've been talking about linking together. And if we bring it together, perhaps through the health train that we were talking about this afternoon, or some other, just bringing the data together in some other way, it tends, like a biobank, we tend to think of releasing to researchers, and a lot of the stuff I think about is around research and the research use of data. We tend to bring that together and package it up as a non-identifiable data set. So we strip out the identifiers and hand it over to the researchers. And there is that sort of light blue chalk firewall between the identifiable data and the non-identifiable data that we hand over, which is probably all very well if we think of all of that data within a closed system. So the next dimension of the problem is that it isn't actually a closed, the orange box in the glorious diagram. It isn't really a closed system though, is it? Because there's all sorts of external data sets that you might be able to re-identify somebody either accidentally or deliberately if you've got enough computer power. So that the idea of de-identification is really difficult. And if you remember, the two standards, the gold standards, if you like, of medical ethics and law for donkey's years have been anonymization and informed consent. So this begins to shake us in our ethics and law thinking, because can we have truly anonymous, de-identified, not re-identifiable data sets? And probably the answer is no. We can't have that. So that's our sort of frame for how have we got to think about legislating for the secondary processing of this already gathered data. And I've put a little spoiler in there, because the law, the GDPR, I'm going to argue gives us quite a lot of opportunities if we're willing to discuss them, argue them, and then take them. And one of those things is it's not an absolute standard of re-identification. It's not the fact that it could theoretically happen. Recital 26 of the GDPR tells us that the criteria would be what's the reasonable likelihood of re-identification. And that might be a useful thing to think about here in this secondary processing. What's reasonably likely? And that begins to challenge that starting point I was talking about, which was about how do people actually think about this? What does reasonable likelihood mean? Is it a legal reasonable likelihood, or is it somehow linked to that range of sensitivities from the very frightened to the bring it on? Okay. Back to words. Everybody's happier. There is quite a bit of uncertainty around the GDPR. And I want to think a little bit about that now, because under the GDPR, you have to have, amongst other things, a legal basis for the processing. And there was a lot of I was going to say fuss, but that sounds really derogatory, doesn't it? There was a lot of concern about whether, or excitement, that the new GDPR in 2016 was moving us towards narrow consent as a privacy-protecting measure. And of course, if you're trying to run a biobank or other big data sharing, narrow consent is really difficult because it suggests that you have to specify exactly what you're going to do. And indeed, Article 411, for those of you who love that sort of thing, says that this has to be very specific. Well, specific, but the implication is very specific. And I don't think that pedantic discussion of language that says, well, if I say research, I've specified it, is going to win any friends there. I think it really does mean a specific processing that you have in mind. But we do have recital 33 lurking in the background that says, well, in terms of medical research, we appreciate that we're going to need broad consent. Now, the lawyers amongst you will know that a recital has a binding effect, but not as much as an article. It's there to tell you about how the articles work. So one of the things we have to do is to work out in the national law and in the European law exactly what they mean by broad consent is okay. What will be the limits of that? So that's the usual route in, because as I say, our ethics standards expect the gold standard to be anonymizations, and if you can't anonymize something, you have to have informed consent for research and for clinical work as well. So how does secondary processing work there? If I've already gathered the data, I've got all those lovely data sets all in red. Well, our problem might be re-identification of de-identified data. And I've already said that the recital 26 tells us, well, we have to be reasonable about that. We have to understand what's possible. And I wonder if the data processing agreements will actually help us there, because that will be able to say, this is what we will do. And that will begin to create a contractual environment where people will be held accountable and responsible for the things that they take on. Okay, so that's the technical problem of re-identification. But we have this other problem of if I've got lots of data sets where it's all on the basis of specified informed consent and it hasn't envisaged this linking of data, so I've not actually written into the consent the linking of data, does the GDPR stop us? Well, in Article 5.1b, we have the idea of compatible processing. So I've gathered data for a legal basis, and I'm allowed to process it if the process, under that legal basis, under that informed consent, effectively, if the processing is compatible. Now, recital 50 tells us a little bit about how that works. And of course, there are limits on compatibility, but I think that's an area where we can really explore what we mean by something being compatible and how reasonable that might be. What is compatible with having gone into the hospital wanting to be treated for whatever disease they find, and then, well, what's compatible with that? You could argue perhaps direct marketing would be a bit of a stretch for compatibility, but the research, continuing the research that has gone towards the treatment that you've received, is that incompatible? Might incompatibility with some sort of opting out make it more acceptable? How can we how can we develop this idea that is there in the GDPR? How can we actually produce something that really works to fulfill aims that are ones that we believe to be good in society? We have competing ends in that way, don't we? We have the competing end of actually doing good, of treating people when they're ill, and the end of privacy as a societal good as well, as in the public interest. And then there's the question, if you can't make it work as compatible, are you left not being able to do this at all? There's an argument about, well, what legal basis might you then use for this new secondary processing, this linking of databases? And there's been a lot of suggestion that you are bound by the legal basis upon which you gathered the data in the first place, the consent. But if we're saying that it's not compatible with the first, that would suggest that there's an end to the first process, legal basis. So one argument that might fly is that this is a new processing requiring a new legal basis. And it might open up the possibility of saying, well, look, this is in the public interest. Oh dear, we've said the public interest. Nobody's really keen on the public interest, are they, anyway? But I'm going to come to the public interest in a moment. Okay. So this is to sort of, I know it's law and it's boring, but it's to show that in the technicality of the GDPR, there's quite a lot of space to play. We've talked a lot also, or previous speakers have mentioned, the notion of privacy compatibility. And I wondered what the function of privacy is, and whether it is really a good human right. What do we mean when we say we have a right to privacy? Now, the starting point is in 1890 with the Warren and Brandeis article, where they sort of start talking about the legal right to privacy, and it's a bit get off my land type of thing. Actually, if you read that article, it could have been written this week. It talks a lot about press intervention and paparazzi and the like, so it's quite an interesting article, timeless, you might say. But can privacy provide a robust and useful normative function in society? If I asked you, what would your reaction be if the local authority, if the gemeente, had put up a CCTV camera outside your house when you got home, pointing at your front door? What would you think? How many of you would think, oh, that's a direct, oh no, informational privacy? No. Yes, those who've got some hands. Others of you who might have been burgled might think, oh, this is good, proprietary privacy. It's going to deter people. Any takers? Oh, one at the back. Anybody who perhaps been beaten up in the street? Not in Maastricht. But if you're thinking, oh, my physical privacy is now protected by the local authority, this is good. No takers for that. But, so, really, I might suggest that it's not really objective at all. It's very subjective. And case-specific, even between what you might disclose to your spouse or your bank manager. These are all different sorts of ways of thinking about privacy. So privacy might just be a barometer of how you fit in society. So what could the law use as a way of perhaps replacing or this right or constraining this right? Well, one way it might say is, well, you can use the public interest as a way of saying, well, we respect that you have this space that you call private, but we need to come into that space for these reasons. And of course, we usually use a utilitarian approach and say, well, it's a matter of utility. But you could also run it as a Kantian sort of thing, to say, well, actually, you're not treating other people as ends in themselves, merely as means to your ends of having privacy, if you know the harms that will be affected by your claim to privacy actually cause difficulties to the other people. Or Rawls and the veil of ignorance, you could use a reasonableness test. Yes, I don't like the idea you're going to come into my, to point the camera at my house, but it is reasonable in the public interest. I can see that. Or as Arendt sort of talking to us in the background, saying, well, no, actually, once you start separating the body and the legal, you're beginning to create a tyranny. I'm wondering, you see, a lot whether confidentiality might help us here. Not thinking of privacy, but thinking of confidentiality, which is actually spelling out, defining an actionable agreement between different people, between researchers, between clinicians and the patient, defining what the reasonableness is, finding an objective, actionable standard. There was a mention earlier about data as property. Now, as good data protection lawyers, we're brought up with the idea that there isn't any property in personal data. But there seems to be quite a lot of personal property and personal data once it's left the data subject and been processed by other people. And of course, there are lots of things that in a Lockean sense would be appropriate. If I've created a data set, then I probably do want the chance to get to nature with my findings pretty quickly. Or I do want the control to ensure that the data subject's consent reaches through. I just wanted to end by rethinking a little bit about what privacy might be, because underpinning a lot of this has been individual freedom and liberty. And we tend, I think, these days to take that as an idea that we have an absolute choice to do whatever we want and live the lives that we want. But I have a feeling that's only really come to us from the late 70s, because when you start looking behind and before that, liberty and freedom was very much about constrained, or rather was very much constrained by morality. Adam Smith writes a book on morality before he writes The Wealth of Nations. John Stuart Mill talks about your freedom, and he was big on freedom, being limited by when you start harming others. So all the time, this is we have individuality, but we are in society. And I wonder if we might reach into existentialism and authenticity to help us here. Because what is it to be a liberal, free person? How do we struggle with that? And I'm wondering if privacy might be useful as a sort of active definition of the self, where we have to struggle to understand our place in society in relation to everyone else, to try and fathom out that conundrum of going into the hospital and remaining private in an essentially social world. Thanks ever so much.
That's all right.
Are there any questions? We'll save the questions for the
Yes,
panel.
of course.
Thank you. Okay. So now we switch over. Unfortunately, due to personal circumstances, Mr. Arno Rutte was not able to present. However, we are humbled and really thankful that Mr. Leonard de Lange, a Dutch politician, member of the House of Representatives, Tweede Kamerlid van de VVD, is sharing his insight about the role of government in healthcare big data. Welcome, Mr. de Lange. Can you hear us?
Yes, I can hear you.
Oh.
Here, the Hague is speaking.
I think they're not hearing it out there.
I'm hearing you. Do you? Hello?
Hi. Yes, we can hear you, but we're trying to make it more that the audience can hear your voice as well.
Okay, perfect.
Yes. Okay. Welcome and thank you.
Yes, it's a great honor to be a part of your symposium. And first of all, I would like to congratulate you with your PhD.
Thank you very much.
And actually, I followed the speeches of the several speakers. Hello, here.
Yeah, we can hear you.
Okay, let's just see what is going.
Yeah, I think it will go. Even de presentatie opstarten.
Okay. Yes, I think we're on now. So if you should, yes, this is your presentation. This is great.
Yes. Okay, now it will work, I think. Yeah. Perfect.
Go ahead.
Okay, then I will start with my point of view on the healthcare research in the area of the Gdpr, the AVG. I think you hear me well?
Yes, we can. Please continue.
Okay. Then I continue. And actually, at the moment, I think I heard some very interesting point of view by a number of speakers. And now I can put something on what's going on in the Netherlands on the topic on healthcare research and what we do with data. And actually, at the moment, you have the situation that on the healthcare, the general practitioner who made a recipe and wants to communicate with the pharmacy, and sometimes are using the fax machine. And I think that's not the way we want to do it in today, and especially not in the future. So we have to change things to do that. And that's I would like to tell you something about what my party, the People's Party for Freedom and Democracy, wants, what we call smart care, slimme zorg. Because in the Netherlands we have to face some challenges, and that I heard before this evening. People are getting older. We can cure people better. And we have a problem with our labor market for people who work in the healthcare. So we have to be make innovations, and we can do more with research and the challenges of that. And after all, we have to look after the costs of healthcare because they increase every year. So we have some challenges in the Netherlands by the healthcare, what's a really good healthcare. But I think most of all, it's really important that we work on the quality of life for people. But, and I heard it before this evening, when you use data, we have some challenges by how do you do that with the law, and especially the new regulations on the General Data Protection Regulation, the AVG. Because it's not allowed to exchange data without permission or informed consent. Sometimes it's possible because it's necessary for the treatment. And there are laws on the law on medical treatment agreement. And it's sometimes possible for other people who are directly involved in the treatment as a replacement for a doctor. And it is possible when there is danger, when there is a vital importance to do that, but when that stops, you must also give a consent to use those data. And I think that gives some challenges by changing and exchange those information. And that's why our government, by our minister Bruno Bruins, is working on data exchange healthcare policy. In the last couple of years, we struggle with this subject, but I think patients must be able to view and manage their own data. The way we do that today, it's quite old, and there were some debates in the parliament were controlled by issues on privacy. But I think that's a problem when we want to do something in future and take the chances, and we have to deal with the threats of today. And that's why we had the idea that all the data, the personal health file, is the ownership of the patients itself. So the patients' organization in the Netherlands, they work on a standard with all the parties together. Also, like a party like Vectis. And they're working on a PGO, the Met My Personal Health File. And I think that is a quite important breakthrough in the whole discussion by transforming the data in the Netherlands in your own file, where you can choose which doctor can use those data. But to do that, we have to change some legal obligations, and this cabinet is working now on at this moment. And then it's important to have a discussion about which data exchange do we want to digitize. So the discussion on which data and how should digital data exchange take place. And for that, it's important, and I go to this slide, that to make some policies about the way the standard you use. I think it is discussed before. And then the importance of speaking the same language. And now the government is also working on a language, how you can exchange those data, because when the standards are different, it is quite difficult. And also what technique you use. And I think it's important that you use a technique who can exchange in all those languages. So at the moment, the government is working on a roadmap on data exchange in the healthcare. And there are the discussions important about the added value. I think the whole discussion on this symposium shows that there is a lot of added value when you work with data and what you can do in the future about exchanging and the chances with all the data to get better cures. And it's supportable on the feasibility. Is it feasible to use those information? Because there must be some use to use it. And also the support. And that's quite important, that people are supporting the ideas to use those data. And I think when I speak with people who are ill, who are a patient, that there is no problem about using the data when it can help to cure the patient. But in Parliament, we have a lot of discussions about privacy. And I think the last speaker talked about that issue. And actually, it's quite actual, because at this moment in the Parliament here in The Hague, they were talking about a recent data breach, what was at a huge care organization in Utrecht. And now the minister is in Parliament to discuss with my colleagues how we can deal with those situations. Because it's not good when there's a data breach, when there are files of young people can be seen by others who are not allowed to see those information. So we have a debate at the moment in the Parliament to do that. And I think that's a problem, because that's put all the good ideas about how you use data for a good use to become smarter and to help healthcare. That makes it more difficult, because you have to sort this of incidents. And I think in the Parliament we talk a lot about incidents, but I think it's important that we see what that digitally will be the new normal. And actually, I'm quite happy that our government is working on that agenda to make it more the new normal. And I think start today for a better quality of life. So I think as a member of a liberal party, that we must face the challenges and get the chance to work with data, and it's quite important for the future to do that. We have to work on issues on privacy, but I think we can find solutions to get that safe. And I think we have to take the chances, because I think when we don't work today on using all those data, what there is in the Netherlands, we miss some chances to get a better quality of life for people. And that's why I'm motivated in the parliament to work on and to make good laws to do that. So I'm quite happy that today, there was a new start on a discussion how to use that from several points of view. But I think it's quite important that it comes together and to work together to get that better, because there are a lot of chances. And when we want to improve healthcare in the Netherlands and in Europe and in the world in the next coming years, we have to be smart on using data and to get those chances. So that's what I can put on the discussion from the Parliament with the actual discussion this evening on data issues here in The Hague.
Thank you very much, Mr. De Lange, for sharing your insights and your knowledge with us. We have a question from, do we have questions from the audience? Yes.
Thank you for your time, first of all, and for your presentation. On your roadmap, I was intrigued by what are your thoughts? We're building to get the patient involved. On the other hand, there's some experience now. Prompts are growing in importance. That means the surveys that the patients are asked to fill out, and we think of them highly to measure quality of care. In my hospital, for instance, patients can visit their files. It happens maybe 1% of cases. So if you have to choose between making technology be able to for people to opt out instead of opting in by actively clicking a button and visiting a page in order to do that, what are your thoughts on the dynamics it will bring in getting these data available?
Yeah, actually, when you choose for a system, you can hear me?
So the experience is that patients, the media ask for patients involved. The clinical practice is that once we cannot withhold data analysis from the patients because it gives them so many better chances of survival, for instance. So if we're going to depend on actively patients asking, are you okay with us analyzing these data, opting in, the risk might be that when you look at data from these questionnaires where 20% of patients fill out the forms, less than 1% of the people actively visit a website to opt in. So what will happen if we're going to depend on this system rather than thinking of smart ways to get consent for people to anonymously share their data?
Yeah, I think it's quite important that you get the involvement of the patients and how they experience their treatment. So we have to look and think of smart systems to get the opinion of the people who are involved, but the anonymization of information, I think that is better, because now you have those questions on opting in or opting out, and actually that makes it more difficult to share the information. And I think it's good when you involve the patient's knowledge and the experiences of the treatment. So I think it's quite good to support those systems to make it more easy to give your opinion.
Yes, so you're suggesting it should be an add-on to the already existing movement of analyzing the data, and a patient can maybe approve actively for a small batch of data that are maybe highly sensitive, but it should not stall it's like the vaccination, right? So a few people don't choose to have a vaccine. That doesn't mean that the larger group should, be missed out on opportunities. But that's an interesting discussion, I think. But
I think you're right. That's also an actual discussion, and I think that's quite important. That because a small group don't want it, we also think of the big group who don't think that there's any problem by using those data. And actually, I think a lot of people, and that are the most of people, want to use those data when it is used to improve the healthcare. So I think we have to look for the majority when there's no problem, but we have to think of a smart system for people who have a problem with it. But I don't think we have to stop those innovations because a minority won't want it.
Thank you for your time.
You're welcome.
Thank you very much. I want to invite all the speakers to sit here and we can have the panel discussion. Mr. Leendert, you will be on the big screen. We will be seeing you, and the questions that are directed to you, we will come here and ask it to you. Please join us for the panel discussion.
De heer Lang, kan ik u vragen om uw presentatie te stoppen met share? Even een knopje drukken.
If I may just continue the discussion we were just starting, I would be interested to hear the perspective of, for instance, Factis and Sam on how do we go about with privacy if we choose. So there's an opt-in system where people actively have to agree to have the data shared, and there's an opt-out system where people, when they have issues, can opt out. And from the breast implant registry, we know that opting out usually involves less than 1% of people actually actively saying, no, I don't want to be involved. So maybe you can connect.
Well, actually, I fully agree with that. I prefer the Swedish system. In Sweden, they say that healthcare data is of national interest. And you have to share the data and to do good research on a good amount of data. And if you don't want your data to use, make an opt-out. But I don't believe in the system of opting in.
Valerie? Sorry.
No, I can only agree with you. I mean, the Netherlands Cancer Registry also has this opt-out system. And out of 110,000 new patients a year, there are 1 or 2 that opt out each year.
So if you were to set up a system where people have to actively opt in, you would answer to 1 or 2 patients per 200,000 cases?
Well, probably a lot more, because you ask people to think about something. People who just got a diagnosis of cancer, who are busy with totally different things than thinking whether they want to share their data with researchers. They are busy with staying alive. So you shouldn't bother patients with that question at that moment.
Sam, what are your thoughts?
Yes, great points. Basically, the forms that the patients sign when they check in either to the emergency room or to the clinic are very different, but they're all the same in that for at least our hospital, it's all really opt-in. We have an open notes system, and so patients, our notes are actually online immediately. So that was designed as sort of a medical legal ploy as well, because of the fact that all the notes are immediately discoverable, and so that also guides how patients, how as practitioners basically dictate our own notes immediately, and because I will receive notes from patients' emails like the day after saying, well, you said this about my history, but actually it's this. And it's only because of something that was maybe translated or dictated differently, but that is immediately available. But it also speaks to the point of what was brought earlier about who owns the data. And so it's the whole opt-in thing for our hospital that, for instance, other people doing data analysis for the opioid situation in our country are already beyond that. So there are folks in our hospital that are actually calling our own patients related to opioid use that I didn't even know was going on. So we have practitioners in our hospital who are already calling our patients related to how many tablets of opioids that were already been used for breast reduction or gender confirmation surgery projects that we didn't even actually know were going on until after they actually had presented the data. That's kind of a big deal to me, at least, knowing that these patients who have traveled to see us or members in our division have already been contacted by other people in our hospital without our even knowledge about this. Is there some line that's already been crossed? So I don't know. I'm just kind of posing the question for folks.
Would it for GDPR standards, would it be beneficial to move towards active participation of people clicking yes, use all my data?
I think
yes.
It's going to be hard. It's a dilemma, isn't it? GDPR is so interesting because it has different routes through, and there are political choices to make about which routes we're going to take through. I think what we've been discussing here, I quite agree with you. The Swedish, the Nordic countries, they're so interesting there. But how far is that a cultural thing as well, that there is a culture of accepting that the data are public? And what are it sort of makes us ask, what are the cultural boundaries of that? What is it the same in the Netherlands? I think there's different cultural states. Then what was coming through to me as well was this idea of co-production, whether the ideas of privacy, concepts of property are not particularly helpful here. I think the GDPR is really interesting on property because it talks about the personal data being data that relate to an individual. It's not my data, it's data that relate to me. So I think that's of itself really interesting. And I wonder if we have to rethink those concepts to ask, well, they might have dealt with the situation for, say, direct clinical stuff, cutting your leg off, giving you an injection, but do they actually apply in the same way to data? So we might have a sort of middle ground at the moment where the Parliament is looking at how do you create something using the current bricks and straw, if you like, of privacy and property. But what's the next conceptual idea after that would be my question.
Another issue is that there are various sources of data. I know from the clinical registries, a lot of the clinicians are responsible for punching it in. It's a very old-fashioned way, maybe, but that's where my question goes to, because clinicians will say, I'm just collecting data for a PhD student of the scientific committee of who and who. We're all here as big data adepts, so we're not at that stage, but those are the worker bees that get it together. So what would be the best alternative source of data entry? I would be curious to hear about what Philips thinks of it, and Parisa, you are comparing all these various sources, and the rest of the panel, of course, as well.
So I'd like to take a slight angle on your question. We have the case where curated data sets have been compiled, for example, in the US, with a large effort going into it, have been anonymized, where they have been created under waiver of consent in the US, HIPAA compliant, where we have in the European Union, even under GDPR, no homogeneous way of assessing even those data. So even in scientific competitions with big data, we struggle that our understanding in the Netherlands is if you could have asked consent, you didn't ask consent, you can't use the data. In Germany, it has been anonymized. It was created under HIPAA-conformant rules. You can compete under those data. Those things of even having interpretation differences for scientific use of data that have been compiled in other geographies, those are the things that we struggle with across the borders. We may not be correct perfectly in our understanding, but those cross-border difficulties, if you've got a lab in Paris, a lab in Hamburg, and a lab in the Netherlands, and the Gdpr is not harmonizing in which competitions with which data sets we can compete, we're not doing ourselves a favor. So the general request I have is that we disentangle the question of a patient has his data follow him or her, like it is in Belgium with the ID card providing that access, which is something that we can do, from this question, the more difficult question of how do we harmonize access to research data that have been compiled so that we can be compliant, which we strive to be in all geographies where we act. That's a bit of the additional difficulty that we have between the Netherlands, France, and Germany.
I have the same experience with the breast cancer data from Denmark. They can connect to the breast implant registry on a patient level, but in the Netherlands, it's unheard of. We can't do that. And the question is how many people suffer in terms of outcome.
Yes, and how much are we holding back valuable research for society where data have been compiled under a jurisdiction, are available under clear data usage agreements for clear scientific purposes, and so it's not the individual level, but even at population level, we struggle.
So it goes back to the vaccine, anti-vaxxers debate, really. But my question was really about what are your smart sources of data without old-fashioned manual typing and all that stuff?
So I think I follow some of the earlier speakers of saying if there is already a database that has been curated, use that. Before going and compiling a new data set, if there's something that already covers a large part of your question, focus the question and then see what you need to do to augment it instead of starting from scratch every time. Because it will be laborious, it will require the consent where we work, it will require curation. It is not that there's a magic wand which will clean the data for you.
Marisa.
I completely agree with Mr. Wishman. What I want to argue also is that we first have to start the conversation about how, what are the rules that we should comply to? What are the variables that we should unify? If we don't do that, then even if we have a lot of data and different databases, we can't compare them. Just like I showed in one of the studies of the PhD, we compared the US data, tried to compare the US data to the Dutch data, and we saw that only 9% of all the variables were comparable. Well, if you do the same with Germany, Belgium, our neighbors, which is from here less than half an hour away, we aren't just not able. We don't know what our neighbors are doing because we can't compare our data. So let's just start the conversation with unifying, with starting the conversation.
Anybody else?
If I can chime in quickly, the European Union is trying to make healthcare data interoperable across the national boundaries. Island solutions will not cut it. You've got migrant workers, you've got people who are traveling. You've got so many situations where people are becoming mobile across national boundaries that you need to harmonize at that level. Ontologies and other things may help, but you need to agree that, I totally agree with you, Parisa, it needs to be agreed early on so that we have interoperability and don't have 40 solutions in the end.
Somebody in the audience? Oh. Anybody else want to comment? Sam?
This could be a topic that's going to last long, its own conference, but I want to throw in this concept of blockchain and security.
Yes.
And the potentials or pitfalls that may or may not be within a decade's worth, since it's a rapidly evolving, let's just say, technology.
Yes, sorry, Ruud.
Yes, hello, Ruud Sellers from Rotterdam. I have a bit of a different question. There was a lot of different talks today about how the big data could improve care of the patients. And we're coming from an age where in the end, if you need any evidence, and when you're saying I'm applying some evidence treatment, then it needs to be from a randomized controlled trial. And now we are learning that we can do a lot of stuff with data, but how in the end are we going to decide whether something's evidence-based? Are we then going to do a randomized control with and without data? Or do we need a new framework of thinking about what is evidence? Can we get the evidence from this observational data?
So your question is, where in the levels of evidence is big data research results?
Yes. Does it already fit in somewhere?
And how about fake data analysis and fake conclusions or fake?
Mm-hmm.
So anybody want to comment on? Please.
Even if well intended, without the fake things there,
yes, of course, sort of disturb that.
There can be spurious correlations, and there's a debate between the correlation of health in the gum area and teeth health and cardiovascular risks. Is that a causal correlation where you can act on it? Or is that just because I'm a sloppy, lazy guy, I don't exercise, and I don't brush my teeth? It's very difficult to just, using retrospective data without an intervention, to try to disentangle a spurious correlation from a causal one that you can act on. So without hypothesizing an intervention and trying it out and validating it under ethics control, you'll have a hard time unless you wait long enough and are willing to do reinforcement learning on population basis. I wouldn't go there.
So the granularity of your big data is of no influence in this? So you can really sub-select a group of people that followed exactly that path?
And as I was saying in part of my introduction, there's choice. So even if you have an accurate representation of what typical people do, to have a causal relationship, you need to take the human behavior into account. So retrospective data can generate a hypothesis. I would argue, but I may be off, that it is not good enough to sort of come to the same level as a prospective randomized controlled trial.
Anybody else want to comment on this? Valerie, well, it's your favorite topic.
To answer your question, I do think we need a new framework. I think, we're not living in the era of evidence-based medicine anymore. But of course, it will not be easy. I think it will be much more challenging to conceptualize this new framework, thinking of observational data. It also depends very much on which question you want to answer. If the outcome is overall survival, for example, in cancer, this is very bias prone. You have to be very careful with extrapolating the results from observational studies into guidelines if you think of overall survival. If you think of other outcomes, for example, unexpected complications, observational data are just fine. You can use them to create guidelines.
One more.
On the subject of interoperability, so how to get data flowing more easily so everybody can work together more easily, to Mr. Wishman, what do you believe are the solution or solutions to that? Is that more standardized data standards such as FHIR, or is that technological revolutions such as the blockchain? What's your take on that?
So blockchain, as also Professor Lin was asking, is for me a way of an immutable ledger. It's one particular implementation. It allows tracking access and other things, but it has other drawbacks on that. Distributed sources of truth, and if you break the blockchain, it's broken everywhere, and suddenly everybody can go there. So I'd separate off the blockchain and the technology. The interoperability, definitely. The standards are helping. The more you have coding and structured information, I hope you would agree with me, and curated information inside of those structures, the better the exchange is. We struggle in the European Union of even for research cohorts of being able to bring together a sizable population for a study because a rare disease in the Netherlands is even rarer than it is in the US. So to be able to deal with the population and the population specifics, there is nothing else than standards and adhering to those standards in spite of healthcare being a nation thing here, because if you want 300 million, 400 million people together, it cannot be that the German record cannot be included in the same study as the Dutch record. So yes, standards across national boundaries, collaboration in that space, and interoperability are important to us. We strive to get there.
Thank you, and thank you for that question. I think the other way of looking at it is actually turning it upside down. We've been talking about a lot of things coming from the government and healthcare and institutions. these days, everything with, and of course this intertwines with privacy, is the fact that patients with rare diseases are able to find each other immediately right now on Facebook groups, on different types of chat room, and really they are able to compare their own treatments and compare and contrast who's received what and where. And so with that, that's a whole entire network of folks that have already conglomerated themselves. And it's just about trying to, of course, validate and make sure they are who they are, and actually understanding what their treatments are in terms of, and that doesn't take much time at all.
Would chime in, if I may, except curating the data, the misunderstandings that are there, so making sure that it is reliable data that they're exchanging. That's the concerns we would have there.
I think I have one last question and then we'll stop. All of you are leaders in the field of big data. You all took the time and the effort to come here, and I'm sure there was something on your mind. I want to get something out of this visit, because you have two busy calendars to be here with if you wouldn't have a purpose. What was your purpose, and did you reach your goal?
My purpose was that the discussion actually about opt-in or opt-out, and well, you started the discussion, and I hope that The Hague is listening with us.
Let's go to The Hague. The Hague, what was your purpose? Because you most certainly have a very busy calendar, and we're really humbled and honored with your presence. What was your purpose and your goal, and did you achieve that? Oh, you're on mute. Sorry. one second. You have to unmute yourself, or my volume needs to go up. We'll get some.
Oops.
Yes.
Yeah.
Yeah.
I think you understand. Yeah. Okay. Yeah. My main goal is to listen to all the experts and to add some of the discussions who are held here at the Politics in The Hague. But what I think, what I take with me with the discussion this evening is the big chances there are when you are using those data to improve healthcare and to work on quality of life. And I think I'm pretty motivated, and my party is motivated to make good legislation to do that, to think what people want. But I think at the end, people want good healthcare, and I think we have to work on that. And that's also a healthcare what's more brighter than only the Netherlands, because the issues on borders, we have to get rid of that and to use it on a good way to improve the quality of life of people. And I think this debate tonight and the PhD study helps to get that on the agenda. So that makes healthcare better.
Okay. We'll continue, Valerie.
Well, to be honest, my most important goal of today was to have Parisa have a successful and unforgettable day. But besides that, I was very curious about the different standpoints, and I got a little bit more optimistic this evening because, as I said in one of my last slides, it's all about cooperation between the public sector, the private sector, and politics. And I got the feeling this evening that we share a vision.
What's your...
I suppose that I came, of course, to have a fantastic... Yes, okay. But to get excited about an interdisciplinary discussion about privacy and the way that we might be able to use big data. And I suppose the thing I wanted to get across was I was delighted to hear how much is going on in The Hague at the moment around privacy and around data protection. It's fantastic that that's going on. But I'd love it if the Netherlands could be seen as the champion of keeping the idea of the development of harmonization in data protection at the center of Europe, because I've got a sense that we almost dropped the ball on the GDPR, and we've got to keep running with it, and we have to have those harmonized legal situations that will enable the sort of things that our colleagues have been talking about.
Yes.
I think you said it nicely in your laudatio. Try try escaping a cold call. So I got pulled in, and I was looking forward to a stimulating exchange and sort of hearing other people's perspective, seeing where they differ, where they're sometimes aligned, and where they're totally aligned. And so it was heartwarming to hear all of the presentations, and it was a wonderful afternoon. Yes, fully.
Sam, you traveled the longest way of all of us.
Oh, no, it was a quick trip, of course. Well, of course, my goal was to help Parisa achieve her penultimate PhD defense, and she did with flying colors, so congratulations again. It was, I was really just heartened to really listen to everyone's contributions and really vigor to big data, from privacy to data. It was heartening also to hear about a 15-year-old project from my hospital as well, to cancer, to data science, to everyone. And it's been wonderful to really share and contribute with everyone. So to that, I congratulate you again.
And I would like to, of course, give the final word to Parisa herself. So maybe you can stand up and come here and finish your roundup. Well done.
Thank you. Thank you all for being here. I'm truly, truly humbled that all of you experts in the field are here, and that we are all sitting next to each other from different industries, from cancer research, a clinician, Professor Lin, all the way from Boston, of course, to law and ethics and industry. That we are here, and because of a PhD dissertation that we started in 2014, we're having this conversation, and we have The Hague here, online meeting, and we're having this conversation, and we're moving forward. Because eventually, as I said before, it's all because the aim is to help that patient that is sitting in front of us. The aim is to improve healthcare and provide the best quality of care that we all can. So with that, I really want to thank you, all of you, my supervisors, and in specifically my parents, and also my partner Merdad, for helping all of us. Meran and Ahmed came all the way from Boston as well, my para-nymph. Thank you all. It's from the bottom of my heart. I am very humbled to have all of you here. I have a small gift for you. Thank you, and it's time for us to go to have a drink and celebrate this evening.
Thanks.